76-year female, temporal artery biopsy is done. Patient is having headache, tenderness over the scalp, upper limb stiffness. Why biopsy is taken? To rule out giant cell arteritis. What is giant cell arteritis? It is granulomatous inflammatory disease of the large and medium arteries. Pathology of giant cell, it is granulomatous inflammation, infiltration of T cells. T cells. So see what the count is that CD4 plus is more than CD8 and macrophages. So multinucleated giant cells. So this is the basic pathology. What are the histological findings on biopsy? There is intimal. So intimal thickening. One is the intimal thickening. Then in elastic laminar fragmentation and what causes loss of vision? So ophthalmic artery is involved. It is blood test can be done ERCP for inflammatory markers. How is treatment? Treatment has to be, this is corticosteroids. Corticosteroids are to be steroids, has to be given prednisolone. It has to be given 60 milligram per day per orally, or methylprednisolone IV. So if there is loss or something, it has to be at least 2 years. Patient becomes back a year later and neck fracture. So steroid causes avascular necrosis, old age, postmenopausal. So what are the risk factors of pathological fracture? LTD, Paget's, osteomalacia, hyperparathyroidism. What pathology of osteoporosis? The normalization, bone density. Mechanism of osteoporosis, excessive bone resorption. So the question will go for osteoporosis. So giant cell arteritis, steroids is you are giving, and then we leads to orthopedic surgery, mechanical theory, biochemical theory. These are the what osteoid is the structure. Then what are the risk factors of osteomalacia, vitamin D deficiency, renal failure, steroid therapy. So this is about the patient where you get a 56-year lady, female, has got bicuspid aortic wall. So admit for laparotomy. Why bicuspid is susceptible to infective? So wall is bicuspid, so it is susceptible because wall has only 2 walls. Stenosis are high risk. What do you think of this case? Congenital bicuspid aortic wall, pathogenesis of endocardial bicuspid wall, narrow stasis, increased conalization, recurrent attacks of infection, progressive fibrosis. So this bicuspid wall has got high risk because it has small. This is the bicuspid, so opening is small. That's why there's chances. The investigation choice of vegetation infect endocarditis. So 2D echocardiography is done, trans-esophageal or trans-thoracic. So what you look, findings, wall regurgitation, leaflet prolapse, dilatation, rupture of the chordae tendineae, then pericardial effusion, ventricular dilation. So what happens in aortic stenosis? There is chance of sudden death because cardiac output is decreased. It can be myocardial infarction or dissection of aorta. Mild picture of aortic stenosis depends upon mild, moderate, severe. So mild, moderate, severe. So this is asymptomatic. This can be angina, syncope attacks, and sudden death. So pathophysiology again lead to sudden death because wall cannot afterload mechanism. So mechanical and tissue walls, what is the difference? Mechanical has a click and this is noiseless. What is non-surgical option for wall replacements? Endovascular treatment, balloon angioplasty. So again, these are the same questions for critical care patients. Which intrinsic factors, what are extrinsic factor, what is the common organisms, CRP is secreted, what are the NICE guidelines for infected endocarditis. So this next station is about a 50-year lady having sickle cell disease, and injury to parietal area, CT scan done, space occupying lesion was found. What is sickle cell disease? Now what is this sickle cell disease? It is hereditary hereditary hemoglobinopathy. So it is hemoglobinopathy. What is caused by point mutation of P globulin? So beta promotes polymer deoxin leading to cell distortion and anemia and microvascular obstruction, ischemia. So what is that? Hemoglobin S is produced substitution of valine. Substitution of valine is substituted for glutamic acid. It is inherited. This is autosomal recessive type, beta globin chromosome 11. Surgical concerns, gallstones. What is concern about surgery? So gallstones, avascular bone necrosis, bowel ischemia, osteomyelitis, wound healing, then anesthesia, heart failure. Why bone pains? Vaso-occlusive triggered by this. Immunocompromise, autosplenectomy may happen. So most common organism causing infection. Then again about splenectomy, NHS, Neisseria, hemophilia, streptococcus pneumoniae. Why do you think of splenectomy? It can be brain tumor, which is most common brain tumor, panicles, gliomas, and medulloblastomas. Meningioma, acoustic neuroma, pituitary tumors, pineal tumors, craniophryngiomas. Natural history of the brain tumors, if left untreated, it increases intracranial pressure that causes herniation and causes compression of respiratory center and death. So metastatic bone tumors, this can be from primary sites. What are the functions of spleen? Hemopoiesis and synthesis. 44-year male seen in the clinic, history of asthma and parathyroid PTH, parathyroid gland surgery, and abdominal pain. So pancreatic disease. So this patient has got pancreatic disease. So what is parathyroid hyperplasia? So non-malignant pathology, proliferation, enlargement of the cells. There are 4 glands, 2 superior, 2 inferior. Microscopy gives chief cells, microscopic feature, most common pattern is chief cell hyperplasia. Less commonly clear cell hyperplasia. Islands of occiput and tensor. 2 top reasons of parathyroid hyperplasia. It can happen because of renal failure or NEN syndrome. So the patient is in the clinic, now collapse, means glucose cannot be immediately measured, later confirmed to less. So repeated attacks of sweating and fainting. So this is related with the pancreatic. So what happens in pancreas? There is insulinoma, pancreatic hyperplasia. So this is one of the things, and parathyroid. Both the things are hyperplasia. This leads to release of insulin, increase insulin, that causes decrease blood glucose level, and patient becomes unconscious or falls suddenly. So beta cells of Langerhans, they are affected. Findings: high detectable insulin level. So how will you define insulinoma? What will be insulinoma? So increase insulin in glucose, and insulin to glucose ratio is also increased. C peptides, these are also increased. Apart from insulin, what are the pathology that create this condition? It can be insulin like growth factor and hepatoma, fibrosarcoma, and sensitivity. Define MEN. Inherent autosomal dominance. It is again autosomal dominant, and it leads to MEN. One has got pituitary, one is pituitary adenoma, parathyroid hyperplasia, pancreatic tumors. So MEN1 gene mutation, So mutation tumor suppressing gene, P10 gene. So inactivation of this leads to most of the common mutation is in suppressor genes. And what is telomere? Telomere is the end repetitive nucleotide sequence at the end of chromosome. So this is the end of chromosome. So repetitive. What are the genes responsible cancer in general? Tumor suppression, proto and oncogenes. Now, what about APN2? So thyroid. Here there is involvement of thyroid in MEN2. So what is there? Medullary thyroid carcinoma. So here there is increased calcitonin. Calcitonin levels are increased. So antithyroid, your medullary thyroid cancer, and it is autosomal dominant parafollicular C cells. Antibodies are linked to the fluorescent dye because it is immunohistochemistry. TNM classification less than 3 cm, more than 4 cm, T3, T2. So this is if you diagnose, and there is pheochromocytoma. So how is MEN2? MEN type 1, MEN2. So MEN2A and 2B rate oncogenes, and this is menu. So there is parathyroid condition is familiar with that. So what is there in pheochromocytoma? There will be plasma urine, catecholamines within mandelic acid, and here you see catecholamines, flea metanephrines. So when to differentiate between MEN1, 2, A and B. So one has got 3 P's: parathyroid hyperplasia, pituitary adenoma, pancreatic tumors, and this P is continued parathyroid hyperplasia, then medullary thyroid cancer, pheochromocytoma. So parathyroid is common, and here you get marfanite and mucosal neuromas. Got fracture femur and hypothyroidism, CA breast. So classical mastectomy is done 5 years ago. So check the lab results and abnormalities. You will be given paper results. Increase urea, creatinine, hyperemia. Possible causes of increase calcium. So what happens? It is bone nets. Chronic kidney disease leads to increased calcium. So what you look for the bone scan, you find increased hot spots in the scan. And what will you do? Why will you do THR hemiarthroplasty, not fixation? Because this doesn't heal, because intracapsular THR here, because metastasis in hypothyroidism, high risk for non-union, malunion. What will you send the femoral head for? Histopathology. Head should be sent for histopathology after doing THR to rule out METs or pathological fracture. Mechanism of action of radiotherapy. How radiotherapy acts? Now radiotherapy causes diminish osteoclasts activation and kill tumor cells, damaging DNA. Direct damage to DNA, cell death, indirect formation of free radicals, and causes cell death. Why radiotherapy other than killing cancer cells? What is the function of radiotherapy apart from killing it? Reduction of the tumor volume. It reduces pain, reduces volume of the tumor. Give 3 causes of pulmonary edema, deviate in patient of THR, hypercoagulability and all that. 2 medication of breast cancer, hormones and all that. Regimen of Herceptin. It has to be taken 3 times. Define mammary Paget cells. Epithelial cells underlying ductal adenocarcinoma. Mechanism of action aromatase converts androgen to estrogen.